Alright, now, let's begin with renal system. First, renal embryology. Kidney embryology. Kidney development begins with the pronephros, which appears in the 4th week of embryogenesis but then degenerates. The mesonephros also develops in the 4th week and functions as the interim kidney during the 1st trimester in both sexes. In males, the mesonephric ducts persist as the Wolffian ducts, which go on to form the ductus deferens and epididymis, while in females the mesonephric ducts degenerate. The metanephros is the permanent kidney, first appearing in the 5th week, and nephrogenesis is normally completed by the 36th week of gestation. The ureteric bud, also called the metanephric diverticulum, is derived from the mesonephric duct and becomes fully canalized by the 10th week. It goes on to form the ureters, renal pelvis, calyces, and collecting ducts. The metanephric mesenchyme, also called the metanephric blastema, interacts with the ureteric bud to induce differentiation and formation of structures from the glomerulus through the distal convoluted tubule. An abnormal interaction between the ureteric bud and the metanephric mesenchyme can result in congenital kidney malformations such as renal agenesis and multicystic dysplastic kidney. The ureteropelvic junction is the last part of the ureter to canalize, and if this process is incomplete, it results in congenital obstruction. This may be unilateral or bilateral and is the most common pathologic cause of prenatal hydronephrosis, which can be detected on prenatal ultrasound. If the fetus cannot produce urine in utero, Potter sequence develops. This occurs because oligohydramnios leads to compression of the developing fetus. The result is limb deformities, such as club feet, facial anomalies, such as low-set ears, retrognathia, and a flattened nose, and chest compression with pulmonary hypoplasia due to lack of amniotic fluid aspiration into the fetal lungs, which is the usual cause of death. Potter sequence may result from chronic placental insufficiency or reduced fetal urine output. Causes of reduced fetal urine output include autosomal recessive polycystic kidney disease, obstructive uropathy, such as posterior urethral valves, bilateral renal agenesis, preterm premature rupture of membranes, and maternal use of ACE inhibitors. The mnemonic to remember Potter sequence is that babies who cannot pee in utero develop Potter sequence. It is characterized by pulmonary hypoplasia, oligohydramnios as the initiating trigger, twisted face, twisted skin, extremity defects, and renal failure in utero. In renal embryology, one important anomaly is the horseshoe kidney. In this condition, the inferior poles of both kidneys fuse abnormally. As the fused kidneys ascend from the pelvis during fetal development, they become trapped under the inferior mesenteric artery and therefore remain low in the abdomen. Despite this abnormal position, kidney function is usually preserved. However, horseshoe kidneys are associated with complications such as hydronephrosis, often due to ureteropelvic junction obstruction, renal stones, recurrent infections, and an increased risk of renal cancer. Horseshoe kidney is also seen more frequently in chromosomal aneuploidies, including Turner syndrome and trisomies 13, 18, and 21. Another congenital condition is the solitary functioning kidney. This refers to being born with only one functional kidney. Most patients are asymptomatic because the contralateral kidney undergoes compensatory hypertrophy, but anomalies of that kidney are common. This condition is often detected prenatally on ultrasound. In contrast, bilateral renal agenesis or severe dysplasia results in Potter sequence, which is incompatible with life. Unilateral renal agenesis occurs when a ureteric bud fails to develop and cannot induce differentiation of the metanephric mesenchyme. This leads to the complete absence of one kidney and its ureter. Multicystic dysplastic kidney arises when the ureteric bud develops, but fails to induce proper differentiation of the metanephric mesenchyme. The result is a non-functional kidney composed of multiple cysts and connective tissue. Although this is a non-genetic condition, it often runs in families and is usually unilateral. A duplex collecting system develops when the ureteric bud bifurcates before it enters the metanephric blastema, creating a Y-shaped ureter. Alternatively, two separate ureteric buds may form and both interact with the metanephric blastema. This anomaly is strongly associated with vesicoureteral reflux and ureteral obstruction, which predispose patients to urinary tract infections and hydronephrosis. Posterior urethral valves represent a different type of anomaly. They occur in males when a remnant membrane persists in the posterior or prostatic urethra. This persistence causes bladder outlet obstruction. Posterior urethral valves are often diagnosed prenatally by the presence of bilateral hydronephrosis and a dilated, thick-walled bladder on ultrasound. Severe obstruction in utero can cause oligohydramnios. Posterior urethral valves are the most common cause of bladder outlet obstruction in male infants. Vesicoureteral reflux. Vesicoureteral reflux refers to the retrograde flow of urine from the bladder back into the upper urinary tract. It can be classified as primary or secondary. Primary vesicoureteral reflux occurs due to abnormal or insufficient insertion of a ureter within the vesicular wall at the ureterovesical junction. Secondary vesicoureteral reflux develops when abnormally high bladder pressure forces urine backward through the ureterovesical junction. Both forms predispose to recurrent urinary tract infections and, if persistent, may lead to renal scarring and long-term kidney damage. Now let's talk about renal anatomy. Renal blood flow. Renal blood flow begins at the renal artery, which branches into segmental arteries, then interlobar arteries, arcuate arteries, and interlobular arteries. From the interlobular arteries, blood enters the afferent arteriole and flows into the glomerulus. Blood that leaves the glomerulus exits through the efferent arteriole and then enters the peritubular capillaries. Venous return follows the interlobular veins, arcuate veins, interlobar veins, and finally the renal vein. In addition, the left renal vein uniquely receives drainage from the left suprarenal vein and the left gonadal vein. The renal medulla receives significantly less blood flow than the renal cortex, making it highly sensitive to hypoxia and prone to ischemic damage, such as acute tubular necrosis. The left renal vein is clinically significant because it is longer than the right, making the left kidney the most commonly taken during living donor transplantation, rule of less. Glomerular anatomy is specialized for filtration. The afferent arteriole delivers blood into the glomerulus, which is enclosed by Bowman's capsule. The filtration barrier consists of three main layers: the fenestrated capillary endothelium, the basement membrane, and the podocytes of the visceral layer of Bowman's capsule. Endothelial cells of the glomerular capillaries form the first layer of this barrier and allow passage of solutes and water, but restrict large proteins and cells. The efferent arteriole carries filtered blood away from the glomerulus and helps maintain glomerular capillary pressure, which is essential for effective filtration. Mesangial cells provide structural support and regulate filtration, while juxtaglomerular cells near the afferent arteriole secrete renin in response to changes in blood pressure. The macula densa, located in the distal convoluted tubule, senses sodium concentration and helps regulate glomerular filtration through tubuloglomerular feedback. Course of ureters. The ureter arises from the renal pelvis and travels retroperitoneally. It passes under the gonadal arteries, then crosses over the common iliac artery at the pelvic brim, and finally travels under the uterine artery in females or under the vas deferens in males before entering the bladder. This relationship is clinically important because gynecologic procedures, such as ligation of the uterine or ovarian vessels, may inadvertently damage the ureter, leading to obstruction or urine leakage. As the ureter enters the bladder, bladder contraction compresses the intramural portion of the ureter, which prevents reflux of urine. There are three common sites of ureteral obstruction: at the ureteropelvic junction, at the pelvic inlet, and at the uretero-vesical junction. A useful mnemonic is water, ureters, flows over the iliacs and under the bridge, where the bridge refers to the uterine artery in females or the vas deferens in males. Now, the next chapter is renal physiology. We will talk about fluid compartments. Okay, let's break this down step by step. Your total body mass is basically made up of two things: water and non-water material. Around 55% to 60% of your body is water, while 40% to 45% is everything else, like fat, protein, bones, and minerals. Now, of all the water in your body, about 2/3 is inside your cells. That's called intracellular fluid. The remaining 1/3 is outside your cells, which we call extracellular fluid. If we zoom into the extracellular fluid, about 75% of it is interstitial fluid, the fluid between cells, and about 25% is plasma, the liquid portion of blood. Red blood cells themselves make up about 10% of total blood volume. So when we talk about blood volume, it equals plasma volume plus red blood cell volume, which is usually around 6 liters in adults. Your hematocrit, which is the percentage of blood volume that is made up of red blood cells, normally runs between 37% to 50%. Here's a fun memory trick. HICN equals high potassium inside cells, intracellularly. That means most of your potassium ions are inside your cells, not outside in the extracellular fluid. Now, here's another classic, the 60-40-20 rule. It goes like this: 60% of body weight equals total body water. 40% of body weight equals intracellular fluid, mainly made up of potassium ions, magnesium ions, and organic phosphates like adenosine triphosphate. 20% of body weight equals extracellular fluid, mainly made up of sodium ions, chloride ions, bicarbonate ions, and albumin. How do we measure these volumes in medicine? Well, doctors can measure plasma volume using radio-labeled albumin, since albumin stays in plasma. To measure extracellular fluid volume, they use special markers like inulin or mannitol. Your serum osmolality, which means how concentrated your blood is with solutes, usually sits between 275 to 295 milliosmoles per kilogram of water. And here's a formula for calculating plasma volume. Plasma volume equals total blood volume multiplied by 1 minus hematocrit. Now, let's move to the glomerular filtration barrier. The glomerular filtration barrier is responsible for filtration of plasma according to size and charge selectivity. It is composed of 3 main parts. The first is the fenestrated capillary endothelium. The second is the glomerular basement membrane, also called GBM, which contains type 4 collagen chains and heparin sulfate. And the third is the visceral epithelial layer, which consists of podocyte foot processes. The charge barrier means the glomerular filtration barrier contains negatively charged glycoproteins that prevent entry of negatively charged molecules, like albumin. The size barrier means the fenestrated capillary endothelium prevents entry of molecules larger than 100 nanometers or blood cells, and the slit diaphragm prevents entry of molecules larger than 40 to 50 nanometers. Podocyte foot processes interpose with the glomerular basement membrane, creating both the charge barrier and the size barrier. Renal clearance is the volume of plasma from which a substance is completely cleared in the urine per unit time. Now let's first learn what these terms mean. Cx is the clearance of X in milliliters per minute. Ux is the urine concentration of X, for example, milligrams per milliliter. Px is the plasma concentration of X, for example milligrams per milliliter. And V is the urine flow rate in milliliters per minute. The formula is clearance of X equals urine concentration of X times urine flow rate divided by plasma concentration of X. If clearance of X is less than the glomerular filtration rate, that means there is net tubular reabsorption or the substance is not freely filtered. If clearance of X is greater than the glomerular filtration rate, that means there is net tubular secretion of X. If clearance of X equals the glomerular filtration rate, that means there is no net secretion or reabsorption. Now, glomerular filtration rate. Inulin clearance can be used to calculate GFR because it is freely filtered and is neither reabsorbed nor secreted. So the formula is clearance of inulin equals GFR equals urine concentration of inulin times urine flow rate divided by plasma concentration of inulin. Another way to write it is filtration coefficient times glomerular capillary hydrostatic pressure minus Bowman space hydrostatic pressure minus glomerular capillary oncotic pressure minus Bowman space oncotic pressure. Bowman space oncotic pressure normally equals 0. PGC means glomerular capillary hydrostatic pressure. PBS means Bowman space hydrostatic pressure. PGC means glomerular capillary oncotic pressure. PBS means Bowman space oncotic pressure. KF means filtration coefficient. Normal GFR is about 100 milliliters per minute. Creatinine clearance is also an approximate measure of GFR. It slightly overestimates GFR because creatinine is moderately secreted by proximal renal tubules. Now, renal blood flow autoregulation. Autoregulatory mechanisms help maintain a constant renal blood flow and glomerular filtration rate to protect the kidney from rapid fluctuations in renal perfusion pressure that could otherwise cause injury and reduce filtration. There are two mechanisms. The first is myogenic. When arterial pressure stretches the afferent arteriole, this mechanically activates vascular smooth muscle, leading to vasoconstriction of the afferent arteriole and a reduction in renal blood flow. The second is tubuloglomerular. Sodium chloride in the filtrate is sensed by macula densa cells, which then drive paracrine vasoconstriction of the afferent arteriole, reducing renal blood flow. This system can also work in the opposite way and increase flow if sodium chloride levels are low. Now, effective renal plasma flow. Effective renal plasma flow can be estimated using para-aminohippuric acid, also called PAH, clearance. Between filtration and secretion, there is nearly complete excretion of all PAH that enters the kidney. The formula is effective renal plasma flow equals urine concentration of PAH times urine flow rate divided by plasma concentration of pH. This is the same as clearance of PAH. Renal blood flow equals renal plasma flow divided by 1 minus hematocrit. Usually, renal blood flow is about 20 to 25% of cardiac output. Effective renal plasma flow underestimates true renal plasma flow slightly. At the nephron, about 20% of PAH is filtered at the glomerulus and the other 80% is secreted in the proximal tubule. This way, 100% of PAH is excreted. Okay, let's talk about filtration and how the kidney fine-tunes blood flow. First, remember the concept of filtration fraction. That's simply your glomerular filtration rate, or GFR, divided by your renal plasma flow, or RPF. On average, this number is about 20%. Next, we have the filtered load. This is just how much of a substance gets filtered through the glomerulus every minute. The formula is GFR multiplied by the plasma concentration of that substance. Easy math. Now, for estimating GFR in real life, we usually rely on creatinine clearance. Creatinine is not perfect, but it's a good approximation because it's filtered and only slightly secreted. Here's a key memory trick. Prostaglandins dilate the afferent arteriole. Remember PDA, prostaglandins dilate afferent. Angiotensin II constricts the efferent arteriole. Think ACE. Angiotensin constricts efferent. That balance is super important for maintaining kidney function. And because of this, you never want to give someone both NSAIDs and ACE inhibitors at the same time. Why? Because NSAIDs block prostaglandins, so the afferent arteriole can't dilate. ACE inhibitors block angiotensin II, so the efferent arteriole can't constrict. Put those together, and you cut blood flow on both ends. Not good for the kidneys. Now, RPF, renal plasma flow, is best estimated using paraminohippuric acid clearance, or PAH clearance. That's because PAH is both filtered and secreted, so pretty much all of it gets excreted. Let's zoom in on the diagram of the glomerulus. Imagine blood flowing into the afferent arteriole, hitting the glomerular capillaries, and then leaving through the efferent arteriole. On the outside, you've got the Bowman capsule, with a parietal layer on one side and podocytes on the visceral side. Inside, you got mesangial cells that help provide support. The basement membrane sits right in the middle of the filter. Beyond the glomerulus, the fluid heads toward the distal tubule, where the macula densa keeps an eye on sodium levels. Right next to it, the juxtaglomerular cells release renin when needed. And don't forget the peritubular capillaries, which pick things up downstream. Now, how does the kidney actually decide how much to filter? It's all about pressures. The formula is net filtration pressure equals PGC plus pi BS minus PBS plus pi GC. Here's what those mean. PGC is glomerular capillary hydrostatic pressure, the pushing force of blood. PBS is Bowman space hydrostatic pressure, the resistance in the capsule. Pi GC is the glomerular capillary oncotic pressure, pulling back because of proteins in the blood. Pi BS is Bowman space oncotic pressure, usually 0, because normally there aren't proteins in Bowman space. Put all together, and you get the balance that determines how much fluid actually moves into the nephron. Now let's go through some scenarios where things change. If you constrict the afferent arteriole, less blood gets in. GFR goes down, renal plasma flow goes down, but the filtration fraction stays the same. If you constrict the efferent arteriole, blood backs up in the glomerulus. GFR goes up, renal plasma flow goes down, and filtration fraction increases. If plasma proteins go up, oncotic pressure inside the glomerulus rises, so GFR drops. RPF doesn't change, so filtration fraction decreases. If plasma proteins go down, the opposite happens. GFR increases, RPF stays the same, and filtration fraction increases. If you constrict the ureter, pressure backs up into Bowman space, reducing filtration. That makes GFR go down, RPF stays the same, so filtration fraction decreases. And finally, in dehydration, both GFR and RPF drop, but RPF falls more than GFR, so filtration fraction actually goes up. Now, here's an important clinical note. If a patient has a nephrectomy, meaning one kidney is removed, their overall kidney function drops right away. That's because you've instantly lost about half the nephrons. So at first, the remaining kidney only provides around 50% of the original function. But over time, the body compensates. The nephrons in the remaining kidney undergo hypertrophy or enlargement to handle more work, and function gradually improves. Okay, now we're moving into calculation of reabsorption and secretion rate. Here's how it works. Filtered load is what gets filtered into the nephron, and it equals glomerular filtration rate multiplied by the plasma concentration of that substance. Excretion rate is what actually leaves your body in urine, and that's urine flow rate multiplied by the urine concentration. Reabsorption rate is simply filtered minus excreted. Secretion rate is excreted minus filtered. Now, an important tool here is fractional excretion of sodium. also called FeNA. This tells us how much of the filtered sodium is actually being excreted. The formula is FeNA equals the amount of sodium excreted divided by the amount of sodium filtered. That means FeNA equals urine flow rate multiplied by urine sodium concentration, divided by glomerular filtration rate multiplied by plasma sodium concentration. Now, since the glomerular filtration rate is equal to urine creatinine concentration multiplied by urine flow rate, divided by plasma creatinine concentration, we can substitute that in. So the final formula becomes FeNA equals plasma creatinine concentration multiplied by urine sodium concentration, divided by urine creatinine concentration multiplied by plasma sodium concentration. All right, let's move on to glucose clearance. At normal plasma levels between about 60 to 120 milligrams per deciliter, all glucose is completely reabsorbed in the proximal convoluted tubule by a sodium-glucose cotransport. But once plasma glucose rises to around 200 milligrams per deciliter, that's when glucose starts spilling into the urine. This is called the threshold. Now, the kidney has a maximum rate at which it can reabsorb glucose, and that's about 375 milligrams per minute. That's known as the transport maximum, or TM. Beyond this point, all the transporters are saturated, so extra glucose just gets excreted. In normal pregnancy, glomerular filtration rate goes up. Because of that, the glucose threshold happens at a lower plasma concentration, so glucosuria can actually show up even when blood glucose is normal. Another important clinical point, SGLT2 inhibitors, these are the frozen drugs, cause glucosuria at plasma glucose levels below 200 milligrams per deciliter. That's how they help treat diabetes. Speaking of which, glucosuria itself is a big clinical clue for diabetes mellitus. Finally, there's this concept called the splay phenomenon. This just means that the transport maximum for glucose isn't reached all at once in every nephron. Some nephrons max out a little earlier, others later, so instead of a sharp cutoff, you get a gradual curve. This is the part of the titration curve between threshold and TM. If you look at the graph, you'll see 3 lines. The filtered glucose load goes up linearly with plasma glucose. The reabsorbed glucose rises too, but then flattens out once TM is reached. The excreted glucose stays at 0 until the threshold, then starts rising as plasma glucose increases beyond what the transporters can handle. And that's how we calculate reabsorption, secretion, and understand glucose clearance. All right, let's dive into nephron transport physiology. We'll start with the proximal convoluted tubule. The early part of the proximal tubule has a brush border, which makes it perfect for reabsorbing lots of stuff. Here, basically all glucose and amino acids are reabsorbed, along with most of the bicarbonate, sodium, chloride, phosphate, potassium, water, and even uric acid. The absorption here is isotonic, meaning water and solutes are reabsorbed together in balance. The proximal tubule also generates and secretes ammonia, or NH3, which helps the kidney get rid of extra acid. Hormones play a role too. Parathyroid hormone inhibits sodium phosphate cotransport, so phosphate gets excreted. Angiotensin II, on the other hand, stimulates sodium-hydrogen exchange, which means more sodium, water, and bicarbonate get reabsorbed. This helps with something called contraction alkalosis. In total, about 65 to 80% of sodium and water are reabsorbed in the proximal tubule. Now, moving down into the thin descending loop of Henle. This part is all about water. It passively reabsorbs water thanks to the hypertonic medulla pulling water out, but it's impermeable to sodium. This makes it the concentrating segment and helps make the urine hypertonic. Next up is the thick ascending limb of the loop of Henle. Here, sodium, potassium, and chloride are reabsorbed through the famous sodium, potassium, 2-chloride cotransporter. The movement of potassium back into the tubule creates a positive lumen potential, which indirectly drives magnesium and calcium to be reabsorbed paracellularly. This segment is impermeable to water, so as the fluid moves up, the urine actually becomes less concentrated. About 10 to 20% of sodium is reabsorbed here. Now, the early distal convoluted tubule. This segment reabsorbs sodium and chloride, but like the thick ascending limb, it is impermeable to water. That makes it the diluting segment, creating hypotonic urine. Parathyroid hormone acts here as well, increasing calcium-sodium exchange and promoting calcium reabsorption. About 5 to 10% of sodium is reabsorbed in this segment. Finally, the collecting tubule. Here, sodium is reabsorbed in exchange for potassium and hydrogen secretion, and this is all under the control of aldosterone. Aldosterone acts on the mineralocorticoid receptor, stimulating messenger RNA and protein synthesis. In principal cells, this increases sodium-potassium pump activity, increases epithelial sodium channel activity, and increases potassium conductance. All of this makes the lumen more negative, driving potassium secretion. In alpha-intercalated cells, the lumen negativity boosts hydrogen ADPase activity, which increases hydrogen secretion and also enhances bicarbonate chloride exchanger activity. Aldosterone is also working here to fine-tune acid-base balance. Antidiuretic hormone, or ADH, acts at the V2 receptor, inserting aquaporin water channels on the apical side of principal cells. This allows water reabsorption, concentrating the urine. About 3 to 5% of sodium is reabsorbed in the collecting duct. Also, note that urea reabsorption happens in the medullary collecting duct, but not in the cortical duct. Now we're moving into renal tubular defects, and an easy way to remember the main ones is the mnemonic Fanconi's bagels. That stands for Fanconi syndrome, Bartter syndrome, Gittleman syndrome, Little syndrome, and SAME, which is syndrome of apparent mineralocorticoid excess. Let's go through them one by one. Fanconi syndrome is a generalized reabsorption defect in the proximal convoluted tubule. Because of this, the kidney wastes amino acids, glucose, bicarbonate, phosphate, and basically all substances normally reabsorbed by the proximal tubule. The effects include metabolic acidosis, also called proximal renal tubular acidosis, hypophosphatemia, and hypokalemia. Causes can be hereditary defects like Wilson disease, tyrosinemia, glycogen storage diseases, ischemia, multiple myeloma, and certain drugs such as ifosfamide, cisplatin, tenofovir, or even lead poisoning. Clinical notes. These patients often have growth restriction, rickets, or osteopenia from low phosphate, and volume depletion is common. Bartter syndrome is a reabsorption defect in the thick ascending loop of Henle. It specifically affects the sodium, potassium, 2-chloride cotransporter. The effects are metabolic alkalosis, hypochloremia, hypokalemia, and hypercalciuria. It is inherited in an autosomal recessive pattern. Clinically, it presents similarly to chronic loop diuretic use. Gittleman syndrome is a reabsorption defect of sodium chloride in the distal convoluted tubule. The effects are metabolic alkalosis, hypochloremia, hypomagnesemia, and hypokalemia. It's also autosomal recessive. This one presents similarly to chronic thiazide diuretic use, and overall it tends to be less severe than Bartter syndrome. Little syndrome is due to a gain-of-function mutation that decreases sodium channel degradation. This means increased sodium reabsorption in the collecting tubules. The effects are metabolic alkalosis, hypokalemia, hypertension, and very low serum aldosterone. It is autosomal dominant. Clinically, it looks like hyperaldosteronism, but aldosterone levels are nearly undetectable. Treatment is with amiloride, which blocks those sodium channels. Finally, we have same syndrome of apparent mineralocorticoid excess. Normally, cortisol can activate mineralocorticoid receptors, but the enzyme 11-beta-hydroxysteroid dehydrogenase converts cortisol into cortisone, which is inactive at those receptors. In same, there is either a hereditary deficiency of 11-beta-hydroxysteroid dehydrogenase or an acquired inhibition, such as from glycyrrhetinic acid found in licorice, which blocks the enzyme. This leads to increased cortisol activity at mineralocorticoid receptors. The effects are metabolic alkalosis, hypokalemia, hypertension, and very low serum aldosterone levels. Remember the phrase, cortisol tries to be the same as aldosterone. It is inherited in an autosomal recessive pattern. Can acquire disorder from glycyrrhetinic acid, present in licorice, which blocks activity of 11-beta-hydroxysteroid dehydrogenase. Treatment options include potassium-sparing diuretics to block mineralocorticoid effects, or corticosteroids to decrease endogenous cortisol production and thereby reduce mineralocorticoid receptor activation. Now we're moving into the features of renal disorders. Here's a quick comparison table that helps us differentiate conditions based on blood pressure, plasma renin, aldosterone, serum magnesium, and urine calcium. For example, syndrome of inappropriate antidiuretic hormone secretion, or SIADH. Blood pressure is normal or increased. Plasma renin is normal or decreased. Aldosterone is normal or decreased. Serum magnesium is normal. Urine calcium is normal. Bartter syndrome. Blood pressure is normal. Plasma renin is increased. Aldosterone is increased. Serum magnesium is normal. Urine calcium is increased. Gittleman syndrome. Blood pressure is normal. Plasma renin is increased. Aldosterone is increased. Serum magnesium is decreased. Urine calcium is decreased. Renin-secreting tumor. Blood pressure is increased. Plasma renin is increased. Aldosterone is increased. Serum magnesium is normal. Urine calcium is normal. Primary hyperaldosteronism. Blood pressure is increased. Plasma renin is decreased. Aldosterone is increased. Serum magnesium is normal. Urine calcium is normal. Little syndrome and syndrome of apparent mineralocorticoid excess. Blood pressure is increased. Plasma renin is decreased. Aldosterone is decreased. Serum magnesium is normal. Urine calcium is normal. That's why this chart is so useful. It gives you the important differentiating features at a glance. Now let's move to the second part, relative concentrations along the proximal tubule. Think of the proximal tubule as a moving conveyor belt where solutes and water are being reabsorbed at different rates. On the graph, you'll see tubular fluid concentration compared to plasma, or TF over P, plotted along the length of the proximal tubule. Here's how to interpret it. If TF over P is greater than 1, that means the solute is either reabsorbed more slowly than water, or it's actually being secreted. If TF over P equals 1, that means the solute and water are being reabsorbed at the same rate. If TF over P is less than 1, that means the solute is being reabsorbed faster than water. Now, let's place some substances on this graph. For glucose and amino acids, their concentration falls below 1 early because they are completely reabsorbed in the proximal tubule. For bicarbonate, its concentration also falls below 1 because it is preferentially reabsorbed. For osmolarity, sodium and potassium, their concentrations stay right around 1 because they are reabsorbed proportionally with water. For chloride, the concentration rises above 1 in the early proximal tubule, since sodium is being reabsorbed along with bicarbonate instead of chloride. Later, chloride reabsorption catches up and the ratio levels off. For inulin and creatinine, their concentrations rise above 1, since neither is reabsorbed and water is being removed, so they get more concentrated as you go along the tubule. Creatinine can rise even more than inulin because it is also secreted. For urea, the concentration also rises above 1 because water is reabsorbed more quickly than urea in the proximal tubule. For parminoippuric acid, or PAH, the concentration rises the most because it is not only filtered but also actively secreted into the tubule. Finally, remember that tubular inulin increases in concentration, but not in amount, as you move along the proximal tubule, since water is being reabsorbed. Chloride reabsorption occurs at a slower rate than sodium in early proximal convoluted tubule, and then matches the rate of sodium reabsorption more distally. Thus, its relative concentration increases before it plateaus. Let's go through the renin-angiotensin-aldosterone system step by step. It all starts in the distal convoluted tubule, where special sensors called macula densa cells live. The RAS gets activated by three main things: a drop in blood pressure, which is picked up by renal baroreceptors; a decrease in sodium chloride delivery sensed by those macula densa cells; and an increase in sympathetic nervous system tone, specifically through beta-1 receptors. From there, the pathway begins at the afferent arteriole. The juxtaglomerular cells release renin. Renin acts on angiotensinogen to form angiotensin I. Angiotensin I is then converted to angiotensin II by angiotensin-converting enzyme, or ACE. ACE has another job as well. It breaks down bradykinin. Now, angiotensin II has multiple effects. It stimulates thirst at the hypothalamus. It binds to the angiotensin II receptor type I and causes vasoconstriction, which raises blood pressure. It preferentially constricts the efferent arteriole. This increases the filtration fraction, which helps preserve the glomerular filtration rate when renal blood flow is decreased. Now inside the kidney cells. In proximal convoluted tubule cells, it increases sodium-hydrogen exchanger activity. That leads to increased sodium, bicarbonate, and water reabsorption, and also contraction alkalosis. In the alpha-intercalated cell, aldosterone increases hydrogen secretion by stimulating hydrogen ADPase activity. In the principal cell, aldosterone increases sodium reabsorption and potassium secretion by increasing potassium conductance, sodium, potassium ADPase activity, and epithelial sodium channel, or ENaC, activity. And it stimulates antidiuretic hormone, ADH, or vasopressin, from the posterior pituitary, which increases water reabsorption through aquaporins. Let's go back to where these molecules are made. Renin is secreted by juxtaglomerular cells in response to decreased renal perfusion pressure in the afferent arteriole, increased renal sympathetic discharge through beta-1 effect, and decreased sodium chloride delivery to the macula densa cells. ACE catalyzes the conversion of angiotensin I to angiotensin II. It is located in many tissues, but the conversion happens most extensively in the lungs. ACE is produced by vascular endothelial cells in the lung. Angiotensin II helps maintain blood volume and blood pressure. It affects baroreceptor function and limits reflex bradycardia, which would normally accompany its pressor effects. ANP and BNP are released from the atria and ventricles in response to increased volume. They relax vascular smooth muscle via cyclic GMP, which increases GFR. They also inhibit the renin-angiotensin-aldosterone system. They dilate the afferent arteriole and promote natriuresis. ADH, also called vasopressin, primarily regulates serum osmolality, but also responds to low blood volume states. It stimulates reabsorption of water in the collecting ducts. It also stimulates reabsorption of urea in the medullary collecting ducts to maximize the corticopapillary osmotic gradient. Finally, aldosterone primarily regulates extracellular fluid volume and sodium content. Its release increases in hypovolemic states. It also responds to hyperkalemia by increasing potassium excretion. The juxtaglomerular apparatus consists of mesangial cells, juxtaglomerular cells, which are modified smooth muscle cells of the afferent arteriole, and the macula densa, which are sodium chloride sensors located in the distal convoluted tubule. Juxtaglomerular cells secrete renin in response to decreased renal blood pressure and increased sympathetic tone through beta-1 receptor stimulation. Macula densa cells sense decreased sodium chloride delivery to the distal convoluted tubule, which promotes renin release, efferent arteriole vasoconstriction, and maintenance of glomerular filtration rate. Communication between juxtaglomerular cells and macula densa occurs via gap junctions. The juxtaglomerular apparatus prevents short-term changes in glomerular filtration rate through autoregulation and maintains glomerular filtration rate long-term through regulation of the renin-angiotensin-aldosterone system. Beta blockers decrease blood pressure by reducing cardiac output and by inhibiting beta-1 receptors of the juxtaglomerular apparatus, which decreases renin release. The kidney also has important endocrine and paracrine functions. Erythropoietin is released by interstitial cells in the peritubular capillary bed in response to hypoxia. It stimulates red blood cell proliferation in the bone marrow and is administered in anemia secondary to chronic kidney disease, though it carries a risk of hypertension in some patients. Proximal convoluted tubule cells convert 25-hydroxy-vitamin D3, or calcidiol, to the active form 1,25-dihydroxy-vitamin D3, or calcitriol, through the action of the enzyme 1-alpha-hydroxylase, which is stimulated by parathyroid hormone. Calcitriol increases calcium absorption in the small intestine. The kidney also produces prostaglandins, which act in a paracrine fashion to vasodilate afferent arterioles and increase renal blood flow. Non-steroidal anti-inflammatory drugs block prostaglandin synthesis, leading to afferent arteriole constriction and decreased glomerular filtration rate, which may precipitate acute kidney injury in states of reduced renal perfusion. In addition, dopamine is secreted by proximal tubule cells and promotes natriuresis. At low doses, dopamine dilates interlobular arteries, afferent arterioles, and efferent arterioles, thereby increasing renal blood flow with little or no change in glomerular filtration rate. At higher doses, dopamine acts as a vasoconstrictor. Hormones acting on kidney. Several hormones exert specific actions on the nephron to regulate sodium, potassium, calcium, water balance, and systemic blood pressure. In the glomerulus, atrial natriuretic peptide is secreted in response to increased atrial pressure. It causes indirect dilation of the afferent arteriole by inhibiting norepinephrine, which increases glomerular filtration rate and enhances sodium filtration. Because there is no compensatory sodium reabsorption in the distal nephron, the net effect is sodium loss and volume loss. Angiotensin II is synthesized in response to decreased blood pressure. It preferentially constricts the efferent arteriole, which increases glomerular filtration rate and filtration fraction. At the same time, it promotes sodium reabsorption in both proximal and distal nephron segments. The overall effect is preservation of renal function in low-volume states, while sodium and water are simultaneously reabsorbed to maintain circulating volume. Parathyroid hormone is secreted in response to decreased plasma calcium, increased plasma phosphate, or decreased plasma 1,25-dihydroxy-vitamin D3. Its actions include increasing calcium reabsorption in the distal convoluted tubule, decreasing phosphate reabsorption in the proximal tubule, and stimulating the production of 1,25-dihydroxyvitamin D3. This active form of vitamin D increases calcium and phosphate absorption from the gastrointestinal tract. In the collecting duct, aldosterone, an antidiuretic hormone, exert key regulatory effects. Aldosterone is secreted in response to decreased blood volume through activation of Angiotensin II and in response to hyperkalemia. It increases sodium reabsorption, potassium secretion, and hydrogen ion secretion. Antidiuretic hormone, or vasopressin, is secreted in response to increased plasma osmolality and decreased blood volume. It binds to receptors on principal cells in the collecting duct, increasing the number of aquaporins and thereby promoting water reabsorption. It also increases reabsorption of urea in the medullary collecting ducts to maximize the corticopapillary osmotic gradient and facilitate urine concentration. Now, let's move to potassium shifts. Potassium homeostasis depends on both total body stores and rapid shifts between the intracellular and extracellular compartments. Factors that move potassium into cells include alkalosis, which drives hydrogen out of cells in exchange for potassium via the reversible hydrogen, potassium exchanger. Beta-adrenergic agonists, which stimulate the sodium-potassium ADPase, and insulin, which also increases sodium-potassium ADPase activity and promotes postprandial cellular uptake of potassium. Factors that shift potassium out of cells and raise extracellular potassium include acidosis, which drives hydrogen into cells in exchange for potassium efflux. Beta-adrenergic blockade, which reduces sodium-potassium ADPase-mediated uptake. Hypoinsulinemia, which prevents normal insulin-mediated uptake of potassium. Digitalis, digoxin toxicity, which inhibits the sodium-potassium ADPase and thereby increases extracellular potassium. Succinylcholine, which depolarizes nicotinic acetylcholine receptors, causing transient potassium release, especially in patients with burns, trauma, or neuromuscular disease. Cell lysis from conditions such as rhabdomyolysis or tumor lysis syndrome, which releases intracellular potassium. And serum hyperosmolality, which causes osmotic movement of water out of cells with potassium following the water efflux, solute drag. Electrolyte disturbances present with different clinical manifestations depending on whether serum concentrations are low or high. In sodium disorders, low sodium concentration, called hyponatremia, causes nausea, malaise, stupor, coma, and seizures, while high sodium concentration, called hypernatremia, causes irritability, stupor, and coma. In potassium disorders, low potassium concentration, or hypokalemia, is characterized on electrocardiogram by the presence of U waves and flattened T waves, along with arrhythmias, muscle cramps, spasms, and weakness. High potassium concentration, or hyperkalemia, is characterized on electrocardiogram by wide QRS complexes and peak T waves, as well as arrhythmias and muscle weakness. Calcium abnormalities also have distinct features. Low calcium concentration, or hypocalcemia, produces tetany, seizures, prolongation of the QT interval on electrocardiogram, twitching such as that seen in Chvostek's sign, and spasm, such as that seen in Trousseau's sign. High calcium concentration, or hypercalcemia, presents with renal stones, bone pain, abdominal pain, increased urinary frequency, and neuropsychiatric changes such as anxiety and altered mental status, classically remembered as stones, bones, groans, thrones, and psychiatric overtones. Magnesium disturbances are also clinically important. Low magnesium concentration, or hypomagnesemia, can present with tetany, torsades de pointes arrhythmia, hypokalemia, and hypocalcemia, particularly when the serum magnesium concentration falls below 1.0 milliequivalents per liter. High magnesium concentration, or hypermagnesemia, produces decreased deep tendon reflexes, lethargy, bradycardia, hypotension, cardiac arrest, and hypocalcemia. Finally, phosphate abnormalities include low phosphate concentration, or hypophosphatemia, which causes bone loss, osteomalacia in adults, and rickets in children, and high phosphate concentration, or hyperphosphatemia, which can lead to renal stones, metastatic calcifications, and hypocalcemia. Acid-base physiology is divided into metabolic and respiratory disorders, depending on whether the primary disturbance involves bicarbonate ion concentration or the partial pressure of carbon dioxide in arterial blood. In metabolic acidosis, the blood pH is decreased. The bicarbonate ion concentration is decreased as the primary abnormality, and the compensatory response is a fall in the partial pressure of carbon dioxide due to immediate hyperventilation. In metabolic alkalosis, the blood pH is increased. The bicarbonate ion concentration is elevated as the primary abnormality, and the compensatory response is a rise in the partial pressure of carbon dioxide due to immediate hypoventilation. In respiratory acidosis, the blood pH is decreased. The partial pressure of carbon dioxide is elevated as the primary abnormality, and the compensatory response is a delayed increase in renal bicarbonate ion reabsorption, which raises serum bicarbonate levels. In respiratory alkalosis, the blood pH is increased. The partial pressure of carbon dioxide is decreased as the primary abnormality, and the compensatory response is a delayed renal excretion of bicarbonate ions, which lowers serum bicarbonate levels. The relationship between these values can be expressed mathematically using the Henderson-Hasselbalch equation. pH equals 6.1 plus the logarithm of the bicarbonate ion concentration divided by 0.03 multiplied by the partial pressure of carbon dioxide. In cases of metabolic acidosis, the adequacy of respiratory compensation can be determined using Winter's formula, which predicts that the partial pressure of carbon dioxide should equal 1.5 times the bicarbonate ion concentration plus 8, with a margin of error of plus or minus 2. If the measured partial pressure of carbon dioxide is greater than the predicted value, there is a concomitant respiratory acidosis, whereas if the measured partial pressure of carbon dioxide is less than the predicted value, there is a concomitant respiratory alkalosis. Now let's move to acidosis and alkalosis. The first step in evaluating an acid-base disorder is to check the arterial blood pH. If the arterial pH is less than 7.35, the patient has acidemia. If the partial pressure of carbon dioxide is greater than 44 millimeters of mercury, this indicates respiratory acidosis. The cause is hypoventilation, which can occur due to airway obstruction, acute lung disease, chronic lung disease, use of opioids or sedatives, or weakening of the respiratory muscles. If the bicarbonate concentration is less than 20 milliequivalents per liter, this indicates metabolic acidosis. To further classify metabolic acidosis, the anion gap must be calculated using the formula. Anion gap equals sodium minus chloride plus bicarbonate. If the anion gap is greater than 12 milliequivalents per liter, the patient has a high anion gap metabolic acidosis. The causes can be remembered with the mnemonic gold mark. Glycols, ethylene glycol, propylene glycol. Oxaprolene, from chronic acetaminophen use. L-lactate, lactic acidosis. D-lactate, exogenous lactic acid. Methanol and other alcohols. Aspirin, in the late effect of overdose. Renal failure, ketones, diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketosis. If the anion gap is normal, between 8 to 12 milliequivalents per liter, the patient has a normal anion gap metabolic acidosis, also called hyperchloremic metabolic acidosis. The causes can be remembered with the mnemonic shards. spironolactone, hyperchloremia or hyperalimentation, Addison disease or acetazolamide use, renal tubular acidosis, diarrhea, saline infusion. If the arterial pH is greater than 7.45, the patient has alkalemia. If the partial pressure of carbon dioxide is less than 36 millimeters of mercury, this indicates respiratory alkalosis. The cause is hyperventilation, which may be triggered by anxiety or panic attacks, hypoxemia, such as from high altitude, early salicylate poisoning, tumors, pulmonary embolism, or pregnancy. If the bicarbonate concentration is greater than 28 milliequivalents per liter, this indicates metabolic alkalosis. To classify metabolic alkalosis, the urine chloride concentration is checked. If the urine chloride concentration is less than 20 milliequivalents per liter, the metabolic alkalosis is saline responsive. Causes include vomiting, recent use of loop or thiazide diuretics, and antacid overuse. If the urine chloride concentration is greater than 20 milliequivalents per liter, the metabolic alkalosis is saline resistant. Causes include hyperaldosteronism, Bartter syndrome, Gittleman syndrome, and current loop or thiazide diuretic therapy. On a plasma bicarbonate versus arterial pH graph, the buffer line represents the normal relationship between bicarbonate concentration and pH. Disturbances shift the patient into different quadrants: respiratory acidosis, metabolic acidosis, respiratory alkalosis, or metabolic alkalosis. In some cases, more than one disturbance can be present, resulting in mixed acidosis or mixed alkalosis. Renal tubular acidosis. Renal tubular acidosis is a group of disorders characterized by defects in renal acid base handling, leading to a non-anion gap metabolic acidosis. The three main types are distal renal tubular acidosis, type 1, proximal renal tubular acidosis, type 2, and hyperkalemic renal tubular acidosis, type 4. Distal renal tubular acidosis, type 1. The primary defect is the inability of the alpha-intercalated cells in the collecting duct to secrete hydrogen ions, H. Because of this, new bicarbonate, HCO3, cannot be generated, resulting in metabolic acidosis. The urine pH remains greater than 5.5, since hydrogen ion secretion is impaired. Serum potassium is typically low, hypokalemia. Causes include amphotericin B toxicity, analgesic nephropathy, congenital anomalies of the urinary tract such as obstruction, and autoimmune diseases such as systemic lupus erythematosus, SLE. This condition is associated with an increased risk for calcium phosphate kidney stones due to persistently high urine pH and increased bone turnover related to buffering of excess hydrogen ions. Proximal renal tubular acidosis, type 2. The defect occurs in the proximal convoluted tubule, where bicarbonate reabsorption is impaired. This leads to excessive bicarbonate loss in the urine and metabolic acidosis. Initially, urine can be acidified by the alpha-intercalated cells in the collecting duct, but this mechanism is not sufficient to overcome the continuous bicarbonate loss. The urine pH is less than 5.5 when plasma bicarbonate is below the resorption threshold, but becomes greater than 5.5 when the filtered bicarbonate load exceeds the resorptive capacity. Serum potassium is usually low, hypokalemia. Causes include Fanconi syndrome, multiple myeloma, and the use of carbonic anhydrase inhibitors. This disorder is associated with an increased risk of hypophosphatemic rickets in cases such as Fanconi syndrome. Hyperkalemic renal tubular acidosis, type 4. The defect results from hypoaldosteronism or resistance to aldosterone. Reduced aldosterone activity leads to hyperkalemia, and high serum potassium decreases ammonium, NH4, synthesis in the proximal tubule, further impairing acid excretion. The urine pH is variable. Serum potassium is high, hyperkalemia. Causes include conditions with decreased aldosterone production, such as diabetic hyperenetism. Use of angiotensin-converting enzyme, ACE, inhibitors, angiotensin receptor blockers, ARBs, nonsteroidal anti-inflammatory drugs, NSAIDs, heparin, cyclosporin, and adrenal insufficiency. It can also occur due to aldosterone resistance, as seen with potassium-sparing diuretics, obstructive nephropathy, or the use of trimethoprim sulfamethoxazole, TMPSMX. The next chapter is renal pathology. Let's begin with casts in urine. Now, why do we care about casts? Well, the presence of casts tells us that hematuria, blood in urine, or pyuria, white blood cells in urine, is coming from the glomerulus or renal tubules, not just anywhere in the urinary tract. For example, in bladder cancer and kidney stones, you may see hematuria, but importantly, no casts. Similarly, in acute cystitis, you'll get pyuria, but again, no casts. Here's a key fact. All casts have a sort of scaffolding made of tam-horseful mucoprotein, also called uromodulin, secreted by renal tubular cells. Think of it like the sticky glue that holds everything together, and fun fact, it also helps prevent urinary tract infections. Now let's break down the types of casts, one by one, with their clinical relevance. Red blood cell casts, seen in glomerulonephritis and hypertensive emergency. If you see them, think glomerular bleeding. White blood cell casts. These point toward tubulointerstitial inflammation, acute pyelonephritis, or even transplant rejection. Granular casts, classic for acute tubular necrosis, and they're often described as muddy brown in appearance. Fatty casts, also called oval fat bodies. These are seen in nephrotic syndrome and are associated with the famous Maltese cross sign under polarized light. Waxy casts. These show up in end-stage renal disease and chronic kidney disease. Hyaline casts. These are a bit nonspecific. You might see them in dehydration after exercise or with diuretic therapy, but they can also be normal. So, when you look at casts, you're basically peeking into the pathology of the nephron itself. Now, let's move on to the nomenclature of glomerular disorders. This is like the language we use to describe how much of the kidney is affected and in what way. Focal means less than 50% of glomeruli are involved. A good example is focal segmental glomerulosclerosis. Diffuse means more than 50% of glomeruli are involved. Classic example, diffuse proliferative glomerulonephritis. Proliferative means the glomeruli are hypercellular, as in membranoproliferative glomerulonephritis. Membranous refers to thickening of the glomerular basement membrane. Example, membranous nephropathy. Primary glomerular disease means the kidney itself is the main target, for example, minimal change disease. Secondary glomerular disease means another systemic illness or organ disease is affecting the kidney, for example, systemic lupus erythematosus or diabetic nephropathy. Glomerular diseases. Glomerular diseases involve important structures such as proteins, red blood cells, the glomerular capillary, endothelial cells, the glomerular basement membrane, podocytes, and the urinary or Bowman space. Depending on the type of damage, glomerular diseases can present as nephritic syndrome, nephrotic syndrome, or nephritic nephrotic syndrome. Nephritic syndrome occurs due to glomerular inflammation. This inflammation causes damage to the glomerular basement membrane, resulting in the leakage of red blood cells into the urine. These appear as dysmorphic red blood cells and cause hematuria. Because of inflammation, the glomerular filtration rate decreases, leading to oliguria and azotemia. The kidney compensates by increasing renin release, which causes hypertension. Proteinuria is usually in the subnephrotic range, less than 3.5 grams per day, but in severe cases it may approach the nephrotic range. The clinical presentation of nephritic syndrome includes hematuria, red blood cell casts in urine, decreased glomerular filtration rate, oliguria, azotemia, and hypertension. Examples of nephritic syndrome include infection-associated glomerulonephritis, Goodpasture syndrome, IgA nephropathy, also called Berger disease, Alport syndrome, and membranoproliferative glomerulonephritis. Nephrotic syndrome occurs due to podocyte damage, which leads to the loss of the normal charge barrier of the glomerular filtration membrane. As a result, there is massive proteinuria greater than 3.5 grams per day. The consequences of this protein loss include edema and hypoalbuminemia. The liver responds with hepatic lipogenesis, which causes hypercholesterolemia. Urine is often frothy due to proteinuria, and fatty casts can be seen. Nephrotic syndrome is also associated with a hypercoagulable state, such as renal vein thrombosis, because of loss of antithrombin 3 in the urine. There is also an increased risk of infection due to loss of immunoglobulin G and soft tissue compromise caused by edema. Clinically, patients present with generalized edema, frothy urine, and complications from hypercoagulability and infection. Nephrotic syndrome may be primary due to direct podocyte damage or secondary due to systemic processes that damage podocytes. Examples include focal segmental glomerulosclerosis, which may be primary or secondary. Minimal change disease, which may be primary or secondary. Membranous nephropathy, which may be primary or secondary. Amyloidosis, which is secondary, and diabetic glomerulonephropathy, which is secondary. Nephrotic syndrome is a mixed condition in which there is severe damage to the glomerular basement membrane. This results in both the loss of red blood cells into the urine and loss of the charge barrier. So patients develop both hematuria and proteinuria. The proteinuria is typically in the nephrotic range, greater than 3.5 grams per day, but features of nephritic syndrome, such as hematuria, red blood cell casts, reduced glomerular filtration rate, oliguria, azotemia, and hypertension are also present. Nephrotic syndrome can occur with any form of nephritic syndrome, but is most commonly seen with diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis. Nephritic syndrome. Infection-related glomerulonephritis is a classic example of nephritic syndrome. It is a type 3 hypersensitivity reaction that results in consumptive hypocomplementemia. In children, it typically occurs about 2 to 4 weeks after infection with group A streptococcus, either from pharyngitis or skin infection. In adults, Staphylococcus aureus is an additional causative agent. On light microscopy, the glomeruli appear enlarged and hypercellular. On immunofluorescence, there is a granular, starry sky, or lumpy-bumpy, appearance due to deposition of immunoglobulin G, immunoglobulin M, and complement C3 along the glomerular basement membrane and mesangium. On electron microscopy, subepithelial immune complex humps are seen. Immunoglobulin A nephropathy, also called Berger disease, often occurs concurrently with respiratory or gastrointestinal tract infections, since immunoglobulin A is secreted by mucosal linings. It shares renal pathology findings with immunoglobulin A vasculitis. On light microscopy, there is mesangial proliferation. On immunofluorescence, there are immunoglobulin A-based immune complex deposits in the mesangium. On electron microscopy, mesangial immune complex deposition is visible. Rapidly progressive glomerulonephritis, or crescentic glomerulonephritis, has a poor prognosis and can be caused by multiple underlying mechanisms. On light microscopy, it shows a characteristic crescent moon shape, with crescents composed of fibrin and plasma proteins, such as complement C3b, along with glomerular parietal cells, monocytes, and macrophages. The immunofluorescence pattern depends on the cause. In Goodpasture syndrome, which is a type 2 hypersensitivity reaction, there is a linear pattern due to antibodies against the glomerular basement membrane and alveolar basement membrane. This causes hematuria and hemoptysis. In pauciimmune forms, there is negative immunofluorescence with no immunoglobulin or complement deposition. These are associated with antineutrophil cytoplasmic antibody, ANCA, associated vasculitides, granulomatosis with polyangiitis, which is linked to proteinase, 3-ANCA or cytoplasmic ANCA, eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis, which is linked to myeloperoxidase ANCA or paranuclear ENCA. In contrast, a granular immunofluorescence pattern is seen in post-streptococcal glomerulonephritis and diffuse proliferative glomerulonephritis. On electron microscopy, findings depend on the underlying cause. Goodpasture syndrome shows breaks in the glomerular basement membrane, necrosis, and crescent formation without deposits, while pauciimmune forms usually show no deposits. Diffuse proliferative glomerulonephritis is often due to systemic lupus erythematosus, hence the phrase wire lupus. Both diffuse proliferative glomerulonephritis and membranoproliferative glomerulonephritis often present with combined features of nephritic and nephrotic syndromes. On light microscopy, diffuse proliferative glomerulonephritis is characterized by wire looping of capillaries. On immunofluorescence, there is a granular pattern. On electron microscopy, subendothelial immune complex deposits are common, though deposits may also be subepithelial or intramembranous. These deposits are typically immunoglobulin G based and often associated with complement C3 deposition. Alport syndrome is due to a type 4 collagen mutation that leads to alterations in the glomerular basement membrane. It is usually inherited in an X-linked dominant pattern. Alport syndrome presents with a triad of eye problems such as retinopathy and anterior lenticulatus, glomerulonephritis, and sensory neural hearing loss. This triad is sometimes remembered as can't see, can't pee, can't hear or be. On light microscopy, there are irregular areas of thinning, thickening, and splitting of the glomerular basement membrane. On immunofluorescence, the findings are initially negative or nonspecific and usually remain negative. On electron microscopy, there is a characteristic basket weave appearance due to irregular thickening and longitudinal splitting of the glomerular basement membrane. Membranoproliferative glomerulonephritis can be divided into type 1 and type 2. Type 1 is often secondary to hepatitis B virus or hepatitis C virus infection. Type 2 is associated with complement 3 nephritic factor, which is an immunoglobulin G autoantibody that stabilizes complement 3 convertase, leading to persistent complement activation and decreased levels of complement 3. On light microscopy, there is mesangial ingrowth with splitting of the glomerular basement membrane, producing the classic tram track appearance on hematoxylin and eosin and periodic acid shift stains. On immunofluorescence, the pattern is granular. On electron microscopy, type 1 shows subendothelial immune complex deposits, while type 2 shows intramembranous deposits, also called dense deposit disease. Nephrotic syndrome. Minimal change disease is often a primary disease, meaning idiopathic in origin, and it is usually triggered by recent infection, immunization, or immune stimulus, sometimes remembered as the 4 eyes. It may rarely be secondary to lymphoma, for example, through cytokine-mediated podocyte damage. This condition is more common in children. On light microscopy, the glomeruli appear normal, although lipid may be seen in proximal tubule cells. On immunofluorescence, findings are negative. On electron microscopy, there is effacement of podocyte foot processes, which is the key diagnostic finding. Focal segmental glomerulosclerosis can be primary, meaning idiopathic, or secondary to conditions such as human immunodeficiency virus, HIV, infection, sickle cell disease, obesity, or congenital malformations. This disease may progress to chronic kidney disease and is more common in Black individuals. On light microscopy, it shows segmental sclerosis and hyalinosis. On immunofluorescence, it is often negative but may sometimes be positive for nonspecific focal deposits of immunoglobulin M, complement component C3, and complement component C1. On electron microscopy, there is effacement of podocyte foot processes. Membranous nephropathy, also called membranous glomerulonephritis, can be primary, for example, due to antibodies against the phospholipase A2 receptor, or secondary to drugs such as nonsteroidal anti-inflammatory drugs, penicillamine, or gold, infections such as hepatitis B virus, hepatitis C virus, or syphilis, autoimmune conditions such as systemic lupus erythematosus, or solid tumors. It carries an increased risk of thromboembolism, such as deep vein thrombosis or renal vein thrombosis. On light microscopy, it shows diffuse capillary and glomerular basement membrane thickening. On immunofluorescence, there is a granular pattern due to immune complex deposition. On electron microscopy, there is a spike in dome appearance caused by subepithelial deposits. Amyloidosis often involves the kidney as the most commonly affected organ. It is associated with chronic conditions that predispose to amyloid deposition, such as AL amyloidosis, AA amyloidosis, or prolonged dialysis. On light microscopy, Congo red staining shows apple-green birefringence under polarized light due to amyloid deposition in the mesangium. On immunofluorescence, AL amyloidosis may be positive for lambda and kappa light chains, while AA amyloidosis is positive for AA protein. On electron microscopy, there is mesangial expansion by amyloid fibrils. Diabetic glomerulonephropathy is the most common cause of end-stage renal disease in the United States. Chronic hyperglycemia leads to non-enzymatic glycation of tissue proteins, which causes mesangial expansion, glomerular basement membrane thickening, and increased permeability. Glomerular hyperfiltration, characterized by glomerular hypertension and increased glomerular filtration rate, results in glomerular hypertrophy and glomerulosclerosis, which further worsen nephropathy. Clinically, it presents with albuminuria, often detected by an increased urine albumin to creatinine ratio. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are renoprotective in this condition. On light microscopy, there is mesangial expansion, glomerular basement membrane thickening, and eosinophilic nodular glomerulosclerosis, known as Kimmel-Steele-Wilson lesions. On immunofluorescence, the staining is nonspecific and usually negative. On electron microscopy, there is prominent thickening of the glomerular basement membrane with expanded mesangium, predominantly due to increased mesangial matrix, along with segmental podocyte effacement. Kidney stones. Kidney stones can lead to severe complications such as hydronephrosis, pyelonephritis, and acute kidney injury. An obstructed stone presents with unilateral flank tenderness, colicky pain radiating to the groin, and hematuria. Treatment and prevention involve encouraging fluid intake. Radiolucent stones can be remembered with the phrase, "I can't see you," which refers to cysteine and uric acid stones. Calcium stones. Calcium oxalate stones are associated with hypocitraturia. On X-ray, they are radiopaque, and on computed tomography, they are hyperdense. The urine crystals are shaped like envelopes or dumbbells. Calcium stones are the most common, making up about 80% of cases and calcium oxalate stones are more common than calcium phosphate stones. They can result from ethylene glycol ingestion, which is antifreeze poisoning, vitamin C overuse, hypocitraturia usually associated with urine pH, and malabsorption, such as Crohn's disease. Treatment includes thiazide diuretics, citrate, and a low-sodium diet. Calcium phosphate stones are associated with increased pH. On X-ray, they are radiopaque, and on computed tomography, they are hyperdense. The urine crystals are wedge-shaped prisms. Treatment is a low-sodium diet and thiazides. Ammonium magnesium phosphate stones, also called struvite stones. These are associated with increased pH. On X-ray, they are radiopaque, and on computed tomography, they are hyperdense. The urine crystals are shaped like coffin lids, also called sarcophagus-shaped. They account for 15% of stones and are caused by infection with urease-positive organisms, such as Proteus mirabilis, Staphylococcus apophyticus, and Klebsiella. These organisms hydrolyze urea to ammonia, leading to urine alkalinization. Struvite stones commonly form staghorn calculi. Treatment is eradication of the underlying infection and surgical removal of the stone. Uric acid stones. These are associated with decreased pH. On X-ray, they are radiolucent, while on computed tomography, they are visible. The urine crystals are rhomboid or rosette-shaped. Uric acid stones make up about 5% of all stones. Risk factors include arid climates and acidic urine pH. There's a strong association with hyperuricemia, such as in gout, and with diseases that cause high cell turnover, such as leukemia. Treatment is alkalinization of urine and allopurinol. Cystine stones. These are associated with decreased pH. On X-ray, they are faintly radiopaque, and on computed tomography, they are moderately radiodense. The urine crystals are hexagonal in shape. Cystine stones result from a hereditary autosomal recessive condition in which the proximal convoluted tubule, cystine reabsorbing, transporter loses function, causing cystinuria. This transporter defect also results in poor reabsorption of ornithine, lysine, and arginine, remembered by the acronym COLA. Because cystine is poorly soluble, stones form in urine, usually beginning in childhood. They can form staghorn calculi. The sodium cyanide nitroprusside test is positive. A memory trick is that 16 stones have 6 sides. Treatment is a low-sodium diet, alkalinization of urine, and chelating agents such as tiopronin or penicillamine if refractory. Hydronephrosis. Hydronephrosis refers to distension or dilation of the renal pelvis and calyces. This condition is most commonly caused by urinary tract obstruction, such as urinary tract stones, severe benign prostatic hyperplasia, congenital obstructions, locally advanced cervical cancer, or injury to the ureter. Other causes include retroperitoneal fibrosis and vesicoureteral reflux. Dilation occurs proximal to the site of pathology. Serum creatinine becomes elevated if the obstruction is bilateral or if the patient has an obstructed solitary kidney. Over time, hydronephrosis leads to compression and possible atrophy of the renal cortex and medulla. Urinary incontinence. Urinary incontinence can occur in several forms, and mixed incontinence has features of both stress incontinence and urgency incontinence. Stress incontinence occurs due to outlet incompetence, either from urethral hypermobility or intrinsic sphincter deficiency. This results in leakage of urine with increased intra-abdominal pressure, such as sneezing or lifting. The bladder stress test is positive, meaning leakage from the urethra is directly observed during coughing or performing the Valsalva maneuver. Stress incontinence is associated with obesity, pregnancy, vaginal delivery, and prostate surgery. Treatment includes pelvic floor muscle strengthening, such as Kegel exercises weight loss, and the use of pessaries. Urgency incontinence occurs due to detrusor muscle overactivity, causing leakage with a sudden urge to void immediately. It is commonly associated with bladder irritation from urinary tract infections, stones, tumors, or pelvic radiation. Treatment involves pelvic floor physical therapy, bladder training through timed voiding, distraction, or relaxation techniques, and pharmacologic options such as antimuscarinic medications like oxybutynin for overactive bladder, or beta-3 adrenergic agonists such as mirabegron and Vibrant. Overflow incontinence occurs due to incomplete bladder emptying, which may be caused by detrusor muscle underactivity or outlet obstruction. This results in leakage of urine with overfilling of the bladder and is confirmed by elevated post-void residual volume on catheterization or ultrasound. Overflow incontinence is associated with urinary retention, polyuria, such as in diabetes, bladder outlet obstruction, such as in benign prostatic hyperplasia, and spinal cord injury. Treatment includes catheterization to relieve retention and addressing the underlying obstruction, such as with alpha blockers for benign prostatic hyperplasia. Acute cystitis. Acute cystitis is an inflammation of a urinary bladder. It presents with suprapubic pain, dysuria, urinary frequency, and urgency. Systemic signs, such as high fever and chills, are usually absent. Risk factors include female sex due to the short urethra, sexual intercourse, indwelling catheter use, diabetes mellitus, and impaired bladder emptying. The causes of acute cystitis include Escherichia coli, which is the most common cause, Staphylococcus saprophyticus, which is seen in sexually active young women, though Escherichia coli is still more common in this group, Klebsiella, Proteus mirabilis, in which urine has an ammonia scent, Enterococcus species. Laboratory findings show a positive leukocyte esterase test. A positive nitrite test indicates the presence of Enterobacteriaceae. Sterile pyuria, which is pyuria with negative urine cultures, could suggest urethritis caused by Neisseria gonorrhoeae or Chlamydia trachomatis. Treatment of acute cystitis is with antibiotics, such as trimethoprim sulfamethoxazole or nitrofurantoin. Acute pyelonephritis. Acute pyelonephritis is characterized by neutrophil infiltration of the renal interstitium. It primarily affects the renal cortex with relative sparing of the glomeruli and blood vessels. Clinical presentation includes fever, flank pain with costovertebral angle tenderness, nausea, vomiting, and chills. Causes include ascending urinary tract infection, most commonly due to Escherichia coli, as well as hematogenous spread to the kidney. Laboratory findings show white blood cells in the urine with or without white blood cell casts. Computed tomography imaging would demonstrate striated parenchymal enhancement. Risk factors include indwelling urinary catheters, urinary tract obstruction, vesicoureteral reflux, diabetes mellitus, and pregnancy, in which progesterone decreases ureteral tone and the gravid uterus causes compression. Complications of acute pyelonephritis include progression to chronic pyelonephritis, renal papillary necrosis, perinephric abscess with possible posterior spread to the adjacent psoas muscle, and urosepsis. Treatment of acute pyelonephritis is with antibiotics. Chronic pyelonephritis. Chronic pyelonephritis is the result of recurrent or inadequately treated episodes of acute pyelonephritis. It typically requires a predisposition to infection, such as vesicoureteral reflux or chronically obstructing kidney stones. Pathologic findings include coarse and asymmetric corticomedullary scarring with blunted calyces. Tubules may contain eosinophilic casts that resemble thyroid tissue, a finding known as thyroidization of the kidney. Acute kidney injury is a sudden decline in renal function characterized by a rise in serum creatinine and blood urea nitrogen. It is divided into prerenal azotemia, intrinsic renal failure, and postrenal azotemia. Prerenal azotemia occurs due to decreased renal blood flow, as seen in hypovolemia, decreased cardiac output, or decreased effective circulating volume in conditions such as heart failure and liver failure. The reduced renal blood flow causes a decreased glomerular filtration rate, and the kidney responds by increasing the reabsorption of sodium, water, and urea in an attempt to preserve volume. Laboratory findings include urine osmolality greater than 500 mg/kg, urine sodium less than 20 milliequivalent L, fractional excretion of sodium less than 1%, and a serum blood urea nitrogen to creatinine ratio greater than 20. Intrinsic renal failure most commonly occurs due to acute tubular necrosis from ischemia or nephrotoxins. Other causes include acute interstitial nephritis, acute glomerulonephritis, vasculitis, hypertensive emergency, thrombotic thrombocytopenic purpura, and hemolytic uremic syndrome. In acute tubular necrosis, patchy necrosis occurs with debris obstructing the tubules, leading to fluid backflow and decreased glomerular filtration rate. Laboratory findings include urine osmolality less than 350 mg/kg, urine sodium greater than 40 milliequivalent L, fractional excretion of sodium greater than 2%, and a serum blood urea nitrogen to creatinine ratio less than 15. Postrenal azotemia occurs due to bilateral urinary outflow obstruction caused by urinary stones, benign prostatic hyperplasia, neoplasms, or congenital anomalies. The obstruction of urine outflow leads to increased tubular pressure and decreased glomerular filtration rate. Laboratory values vary depending on the duration and stage of the obstruction. Acute interstitial nephritis, also called tubulointerstitial nephritis, is an acute inflammation of the renal interstitium. It is characterized by pyuria, classically with eosinophils, and azotemia, usually occurring after the administration of drugs that act as haptens and induce a hypersensitivity reaction. Common drugs that cause this include diuretics, rifampin, antibiotics such as penicillins and cephalosporins, proton pump inhibitors, nonsteroidal anti-inflammatory drugs, and sulfa drugs. Less commonly, acute interstitial nephritis can occur secondary to systemic infections such as mycoplasma, or systemic inflammatory conditions such as Sjogren's syndrome, systemic lupus erythematosus, or sarcoidosis. Clinical features include fever, rash, pyuria, hematuria, and costovertebral angle tenderness, although in some cases it can be asymptomatic. A useful mnemonic to remember the drug causes is DRAINS, which stands for diuretics, rifampin, antibiotics including penicillins and cephalosporins, inhibitors of proton pumps, nonsteroidal anti-inflammatory drugs, and sulfa drugs. Acute tubular necrosis is the most common cause of intrinsic acute kidney injury in hospitalized patients. It resolves spontaneously in many cases but can be fatal, especially during the initial oliguric phase. A key finding is an increased fractional excretion of sodium and the presence of granular casts, which are often muddy brown in appearance. The condition progresses through 3 stages. The first stage is the inciting event. The second stage is the maintenance phase, which is oliguric and lasts 1 to 3 weeks. During this phase, there is a risk of hyperkalemia, metabolic acidosis, and uremia. The third stage is the recovery phase, which is polyuric. In this phase, blood urea nitrogen and serum creatinine levels fall, but there is a risk of hypokalemia and renal wasting of other electrolytes and minerals. Acute tubular necrosis can be caused by ischemic or nephrotoxic injury. Ischemic injury occurs secondary to decreased renal blood flow, as seen in prerenal azotemia. This results in the death of tubular cells that may slough into the tubular lumen, with the proximal tubule and thick ascending limb of the loop of Henle being particularly susceptible to injury. Nephrotoxic injury occurs secondary to toxic substances such as aminoglycosides, radiocontrast agents, lead, cisplatin, ethylene glycol, or uric acid released in tumor lysis syndrome. It can also result from myoglobinuria in rhabdomyolysis or hemoglobinuria. In nephrotoxic injury, the proximal tubules are especially vulnerable. Diffuse cortical necrosis is another severe renal condition, characterized by acute, generalized cortical infarction of both kidneys. It is thought to result from a combination of vasospasm and disseminated intravascular coagulation. It is often associated with obstetric catastrophes, such as placental abruption and with septic shock. Renal papillary necrosis is characterized by the sloughing of necrotic renal papillae, leading to gross hematuria. It may be triggered by a recent infection or an immune stimulus. It is associated with sickle cell disease or trait, acute pyelonephritis, chronic analgesic use, such as nonsteroidal anti-inflammatory drugs, and diabetes mellitus. A useful mnemonic is SOD-PAPA, which stand for sickle cell disease, acute pyelonephritis, analgesics, and diabetes mellitus as causes of papillary necrosis. The consequences of renal failure are numerous. A decline in renal filtration leads to excess retained nitrogenous waste products and multiple electrolyte disturbances. The consequences can be remembered by the mnemonic MAD hunger. M and AA stand for metabolic acidosis. D stands for dyslipidemia, especially hypertriglyceridemia. H stands for high potassium or hyperkalemia. U stands for uremia. N stands for sodium and water retention, leading to heart failure, pulmonary edema, and hypertension. G stands for growth retardation and developmental delay. E stands for erythropoietin deficiency, causing anemia. R stands for renal osteodystrophy. There are two forms of renal failure: acute, as in acute tubular necrosis, and chronic, as in cases due to hypertension, diabetes mellitus, or congenital anomalies. Chronic kidney disease is defined by incremental reductions in glomerular filtration rate that define the stages of progression. During the early stages of chronic kidney disease, normal phosphate levels are maintained due to increased levels of fibroblast growth factor 23, which promotes renal excretion of phosphate. A useful phrase to remember is that fibroblast growth factor 23 fights phosphate. Uremia is the syndrome that results from high serum urea levels. It can present with pericarditis, encephalopathy with hysterexis, anorexia, and nausea. A way to remember this is the phrase European, standing for uremia causing pericarditis, encephalopathy, anorexia, and nausea. Renal osteodystrophy is a bone disorder associated with chronic kidney disease. It is caused by hypocalcemia, hyperphosphatemia, and the failure of vitamin D hydroxylation. These changes lead to secondary hyperparathyroidism, and if the condition is poorly managed, it can progress to tertiary hyperparathyroidism. High serum phosphate binds with calcium, which causes tissue deposits and further decreases serum calcium. In addition, the low levels of 1,25-dihydroxyvitamin D3 reduce intestinal calcium absorption. The net effect is bone disease with subperiosteal thinning of bones. Renal cyst disorders include several inherited and acquired conditions. Autosomal dominant polycystic kidney disease is characterized by numerous cysts in the cortex and medulla, which cause bilateral enlarged kidneys and ultimately destroy kidney parenchyma. Patients may present with flank pain, hematuria, hypertension, urinary tract infections, and progressive renal failure, which occurs in about 50% of individuals. It is caused by mutations in genes encoding polycystin proteins, either PKD1 on chromosome 16, accounting for about 85% of cases, or PKD2 on chromosome 4, accounting for about 15%. Complications include chronic kidney disease and hypertension due to increased renin production. It is also associated with Barry aneurysms, mitral valve prolapse, benign hepatic cysts, and diverticulosis. If hypertension or proteinuria develops, treatment is with angiotensin-converting enzyme inhibitors or angiotensin receptor blockers. Autosomal recessive polycystic kidney disease is due to mutations in PKHD1, which encodes fibrocystin. It is characterized by cystic dilation of the collecting ducts and often presents in infancy. It may be seen on prenatal ultrasound and is associated with congenital hepatic fibrosis. Severe oliguric renal failure in utero can lead to Potter sequence. In survivors beyond the neonatal period, there is risk of systemic hypertension, progressive renal insufficiency, and portal hypertension due to congenital hepatic fibrosis. Autosomal dominant tubulointerstitial kidney disease, also called medullary cystic kidney disease, causes tubulointerstitial fibrosis and progressive renal insufficiency. Affected patients are unable to concentrate urine. Medullary cysts are usually not visualized, and the kidneys appear smaller on ultrasound. The prognosis is poor. Renal cysts can also be simple or complex. Simple cysts are filled with ultrafiltrate and appear anechoic on ultrasound. They are very common, account for the majority of all renal masses, are usually found incidentally, and are typically asymptomatic. Complex cysts, on the other hand, are septate, show enhancement, or have solid components on imaging. These require follow-up or removal because of the possibility of renal cell carcinoma. Renovascular disease occurs when narrowing of the renal artery leads to ischemia in the kidney. Ischemia stimulates renin release from the juxtaglomerular cells. Renin acts on angiotensinogen, converting it into angiotensin I. Angiotensin I is further converted to angiotensin II. Angiotensin II causes vasoconstriction, which raises blood pressure. In addition, angiotensin II stimulates the release of aldosterone. Aldosterone increases sodium retention, which also contributes to hypertension. Renal artery stenosis can occur in different regions of the renal artery, the proximal 1/3 and the distal 2/3. Proximal 1/3 narrowing is typically associated with atherosclerotic plaques, while distal 2/3 narrowing is more commonly associated with fibromuscular dysplasia. The combined effects of vasoconstriction, aldosterone-mediated sodium retention, and ischemia ultimately result in systemic hypertension. Unilateral or bilateral renal artery stenosis reduces renal perfusion, which increases renin release, angiotensin production, and causes secondary hypertension. This is the most common cause of secondary hypertension in adults. The main causes of renal artery stenosis are atherosclerotic plaques, which typically occur in the proximal 1/3 of the renal artery and are usually seen in older males and smokers, and fibromuscular dysplasia, which affects the distal 2/3 of the renal artery or segmental branches, usually in young or middle-aged females. In unilateral renal artery stenosis, the affected kidney can atrophy, resulting in asymmetric kidney size. Renal venous sampling will show increased renin in the affected kidney and decreased renin in the unaffected kidney. In bilateral renal artery stenosis, patients may develop a sudden rise in creatinine after starting angiotensin-converting enzyme inhibitors. Angiotensin receptor blockers, or direct renin inhibitors, due to their interference with renin-angiotensin-aldosterone system, mediated renal perfusion. Clinical presentation can include severe or refractory hypertension, flash pulmonary edema, and an epigastric or flank bruit. Patients with renal artery stenosis may also have stenosis in other large vessels. Renal cell carcinoma is the most common primary renal malignancy. It is composed of polygonal clear cells filled with accumulated lipids and carbohydrates. On gross pathology, the tumor often appears golden yellow due to high lipid content. Renal cell carcinoma originates from the proximal convoluted tubule, invades the renal vein, and can extend into the inferior vena cava. It spreads hematogenously and frequently metastasizes to the lung, bone, and liver. The classic triad of presentation includes flank pain, a palpable abdominal mass, and hematuria. Other manifestations can include anemia, secondary polycythemia due to increased erythropoietin production, fever, and weight loss. Treatment of localized disease involves surgical resection or ablation. For metastatic disease, therapy includes immunotherapy, such as ipilimumab or targeted therapy. However, it is rarely curative. Renal cell carcinoma is resistant to both radiation therapy and chemotherapy. Renal cell carcinoma most commonly occurs in males between 50 and 70 years old, with increased incidence among tobacco smokers and obese individuals. It is associated with paraneoplastic syndromes, summarized by the acronym PAIR, parathyroid hormone, related peptide, ectopic erythropoietin, adrenocorticotropic hormone, and renin. The clear cell subtype, which is the most common, is associated with deletion of a gene on chromosome 3, either sporadically or inherited in von Hippel-Lindau syndrome. The association can be remembered as renal cell carcinoma has 3 letters, involves chromosome 3, and is linked to von Hippel-Lindau syndrome, which also has 3 letters. Renal oncocytoma is a benign epithelial cell tumor that arises from the collecting ducts. Grossly, it appears as a well-circumscribed mass with a central scar. Microscopically, it is composed of large eosinophilic cells with abundant mitochondria but without paranuclear clearing, which helps distinguish it from chromophobe renal cell carcinoma. Clinically, it presents with painless hematuria, flank pain, and an abdominal mass. It is often resected to exclude malignancy, such as renal cell carcinoma. Nephroblastoma, Wilms tumor, is the most common renal malignancy of early childhood, typically occurring between ages 2 and 4. It contains embryonic glomerular structures and usually presents with a large, palpable, unilateral flank mass, hematuria, and sometimes hypertension. Wilms tumor is associated with loss-of-function mutations in tumor suppressor genes WT1 or WT2 on chromosome 11. It may occur as part of several syndromes. WAGR complex, Wilms tumor, aniridia, absence of iris, genitourinary malformations, and range of developmental delays caused by WT1 deletion. Dennis-Drash syndrome, Wilms tumor, diffuse mesangial sclerosis, leading to early-onset nephrotic syndrome, dysgenesis of gonads, male pseudohermaphroditism, and WT1 mutation. Beckwith-Weidman syndrome, Wilms tumor with increased organ size, organomegaly, macroglossia, tongue enlargement, hemihyperplasia, imprinting defect causing overexpression, omphaloceal, and is associated with WT2 mutation. Urothelial carcinoma of the bladder, also called transitional cell carcinoma, is the most common tumor of the urinary tract system and can occur in the renal calyces, renal pelvis, ureters, and bladder. It typically presents as painless hematuria without casts. Risk factors can be remembered with a mnemonic PSAC. Phenacetin, smoking, tobacco, aromatic amines found in dyes, and cyclophosphamide. Squamous cell carcinoma of the bladder arises due to chronic irritation of the urinary bladder, which leads to squamous metaplasia, dysplasia, and eventually squamous cell carcinoma. Risk factors can be remembered with the 4 S's. Schistosoma hematobium infection, endemic in the Middle East, chronic cystitis, smoking, and stones, chronic nephrolithiasis. It also typically presents with painless hematuria without casts. Now let's move to another chapter, renal pharmacology. Diuretics, site of action. Diuretics act on different parts of the nephron to increase urinary sodium and water excretion. Each drug class targets a specific transporter or channel. Mannitol, an osmotic diuretic, increases tubular fluid osmolarity throughout the nephron, particularly in the proximal tubule and descending limb of the loop of Henle, thereby increasing water excretion. Acetazolamide acts on the proximal convoluted tubule by inhibiting carbonic anhydrase, leading to decreased reabsorption of bicarbonate and sodium. Loop diuretics, for example, furosemide, bumetanide, torsemide, ethacrynic acid, act on the thick ascending limb of the loop of Henle by inhibiting the sodium, potassium, 2 chloride symporter, thereby preventing sodium, potassium, and chloride reabsorption and abolishing the medullary concentration gradient. Thiazide diuretics, for example, hydrochlorothiazide, chlorthalidone, indapalmide, act on the distal convoluted tubule by inhibiting the sodium chloride symporter, reducing sodium and chloride reabsorption. Potassium-sparing diuretics act on the collecting tubules. Amiloride and triamterene block the epithelial sodium channels, while spironolactone and eplerenone antagonize aldosterone receptors, reducing sodium reabsorption and preventing potassium excretion. Diuretics, effects on electrolyte excretion. Carbonic anhydrase inhibitors increase sodium excretion, increase bicarbonate excretion, increase potassium excretion, increase chloride excretion, no change in calcium excretion, no change in magnesium excretion, and decrease hydrogen ion excretion. Loop diuretics increase sodium excretion, decrease in bicarbonate excretion, increase potassium excretion, increase chloride excretion, decrease calcium excretion, increase magnesium excretion, and increase hydrogen ion excretion. Thiazide diuretics increase sodium excretion, increase in bicarbonate excretion, increase potassium excretion, increase chloride excretion, decrease calcium reabsorption, no change or slight increase in magnesium excretion, and increase hydrogen ion excretion. Potassium-sparing diuretics increase in sodium excretion, no change in bicarbonate excretion, decrease potassium excretion, increase chloride excretion, decrease or no change in calcium excretion, decrease or no change in magnesium excretion, and decrease hydrogen ion excretion. Blood pH. Decreased blood pH. Acidemia carbonic anhydrase inhibitors cause decreased bicarbonate reabsorption. Potassium-sparing diuretics cause acidemia because aldosterone blockade prevents potassium secretion and hydrogen ion secretion. Additionally, hyperkalemia leads to potassium entering all cells via the hydrogen potassium exchanger in exchange for hydrogen ions exiting cells. Increased blood pH, alkalemia loop diuretics, and thiazide diuretics cause alkalemia through several mechanisms. Volume contraction leads to increased angiotensin II, which increases sodium-hydrogen exchange in the proximal convoluted tubule, increasing bicarbonate reabsorption, also called contraction alkalosis. Potassium loss leads to potassium exiting all cells via the hydrogen-potassium exchanger in exchange for hydrogen ions entering cells. In low potassium states, hydrogen ions rather than potassium are exchanged for sodium in the cortical collecting tubule, leading to alkalosis and paradoxical aciduria. Mannitol is an osmotic diuretic that increases serum osmolality, causes fluid shift from interstitium to intravascular space, increases urine flow, and decreases intracranial and intraocular pressure, thereby augmenting diuresis. It is used in drug overdose, elevated intracranial pressure, and elevated intraocular pressure. Adverse effects include dehydration, hyponatremia or hypernatremia, and pulmonary edema. It is contraindicated in anuria and heart failure. Acetazolamide is a carbonic anhydrase inhibitor that causes self-limited sodium bicarbonate diuresis and decreases total body bicarbonate stores, thereby alkalinizing urine. It is used in glaucoma, metabolic alkalosis, altitude sickness by offsetting respiratory alkalosis, and idiopathic intracranial hypertension, also called pseudotumor cerebri. Adverse effects include proximal renal tubular acidosis type 2, paresthesias, ammonia toxicity, sulfa allergy, and hypokalemia. It also promotes calcium phosphate stones, which are insoluble at high urine pH. A useful mnemonic is that acid azolamide causes acidosis. Loop diuretics. Furosemide, bumetanide, and torsemide are sulfonamide loop diuretics that inhibit the sodium, potassium, 2-chloride cotransport system of the thick ascending limb of the loop of Henle. They abolish hypertonicity of the medulla, preventing concentration of urine. They also stimulate prostaglandin release, which has a vasodilatory effect on the afferent arteriole, and this effect is inhibited by nonsteroidal anti-inflammatory drugs. Loop diuretics increase calcium excretion and therefore loops lose calcium. They are used in edematous states such as heart failure, cirrhosis, nephrotic syndrome, pulmonary edema, as well as in hypertension and hypercalcemia. Adverse effects include ototoxicity, hypokalemia, hypomagnesemia, dehydration, sulfa allergy, metabolic alkalosis, interstitial nephritis, and gout. Remembered by the mnemonic, oh dang. Ethacrynic acid is a non-sulfonamide inhibitor of the sodium, potassium, 2-chloride cotransport system of the thick ascending limb of the loop of Henle. It is used for diuresis in patients allergic to sulfa drugs. Its adverse effects are similar to furosemide, but it is more ototoxic, remembered by the mnemonic loop earrings hurt your ears. Another one is thiazide diuretics. Hydrochlorothiazide, chlorthalidone, and metolazone are thiazide diuretics that inhibit sodium chloride reabsorption in the early distal convoluted tubule, thereby decreasing the diluting capacity of the nephron and decreasing calcium excretion. They are used in hypertension, heart failure, idiopathic hypercalciuria, nephrogenic diabetes insipidus, and osteoporosis, and they potentiate loop diuretics in refractory volume overload. Adverse effects include hypokalemic metabolic alkalosis, hyponatremia, hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, and sulfa allergy. Remember as hypergluck. Next, potassium-sparing diuretics. Spironolactone, eplerenone, amiloride, and triambarene are potassium-sparing diuretics. Remember as keep your seat. Spironolactone and eplerenone are competitive aldosterone receptor antagonists in the cortical collecting tubule, while triambarene and amiloride block sodium channels at the same part of the tubule. They are used in hyperaldosteronism, heart failure, hepatic ascites, which is treated with spironolactone, nephrogenic diabetes insipidus, which is treated with amiloride, and as antiandrogens with spironolactone. Adverse effects include hyperkalemia, which can lead to arrhythmias, endocrine effects with spironolactone, such as gynecomastia and antiandrogen effects, and metabolic acidosis. Now, angiotensin-converting enzyme inhibitors. Captopril, enalapril, lisinopril, and ramipril are angiotensin-converting enzyme inhibitors that inhibit angiotensin-converting enzyme, thereby decreasing angiotensin II and decreasing glomerular filtration rate by preventing constriction of efferent arterioles. Renin levels increase due to loss of negative feedback. Inhibition of angiotensin-converting enzyme also prevents inactivation of bradykinin, a potent vasodilator. These drugs are used in hypertension, heart failure, where they decrease mortality, proteinuria, and diabetic nephropathy. They also prevent unfavorable heart remodeling as a result of chronic hypertension. In chronic kidney disease, such as diabetic nephropathy, they decrease intraglomerular pressure and slow glomerular basement membrane thickening. Adverse effects include cough and angioedema, both due to increased bradykinin and contraindicated in C1 esterase inhibitor deficiency. teratogenicity leading to fetal renal malformations, increase in creatinine due to decreased glomerular filtration rate, hyperkalemia, and hypotension. They must be used with caution in bilateral renal artery stenosis because angiotensin-converting enzyme inhibitors will further decrease glomerular filtration rate and may cause renal failure. Remember by captoprils catch. Alright, next angiotensin II receptor blockers. Losartan, candesartan, and valsartan are angiotensin II receptor blockers that selectively block binding of angiotensin II at 1 receptors. Their effects are similar to angiotensin-converting enzyme inhibitors, but they do not increase bradykinin. They are used in hypertension, heart failure, proteinuria, and chronic kidney disease, such as diabetic nephropathy in patients who are intolerant to angiotensin-converting enzyme inhibitors because of cough or angioedema. Adverse effects include hyperkalemia, decreased glomerular filtration rate, hypotension, and teratogenicity. Next, aliskiren is a direct renin inhibitor that blocks conversion of angiotensinogen to angiotensin I. Remember, by aliskiren kills renin. It is used in hypertension. Adverse effects include hyperkalemia, decreased glomerular filtration rate, hypotension, and angioedema. It is relatively contraindicated in patients already taking angiotensin-converting enzyme inhibitors or angiotensin II receptor blockers and is contraindicated in pregnancy.